I made a video back in 2025 about the 8 All-on-X lessons that I wish I knew before I started doing these cases. And that video was about the mistakes, the things that I had to learn the hard way. But in this one, I'm going to go and do something a little bit different for you. I'm literally going to break down the entire All-on-X process, the most efficient and the best way that I personally know how to do these cases in 2026. And this process is going to allow you to do full arches in 1 hour or less once you become proficient at it. It's going to lessen your stress for you and your team and your patient. And this process makes the All-on-X procedure, which is routinely taking doctors hours upon hours or is done poorly, seem like any other predictable bread and butter procedure. For the most part, that is. So instead of talking about surface level lessons or tips here and there, I'm going to break down my personal process from start to finish for you. So here's what we're going to cover in this video. Most importantly, I'm going to start with a great differentiator. I'll explain what that means here in a moment. I'm also going to go over my workflow when it comes to planning these cases, my pre-surgery setup, the surgical setup, the immediate teeth, the healed visits, and the finals. And finally, the marketing reality, getting you patients for these procedures. The reality of actually getting these All-on-X patients. If you don't dial in every single one of these pieces, including your team, the whole process is going to become stressful, it's going to be slow, and it's going to be unpredictable. And your patients are going to be pissed. And when they're pissed, they're going to make your life hell. But when the system is dialed in, the surgery is going to become calm, it's going to become efficient, it's going to become predictable 99% of the time. So in this video, I'm going to break down our modern All-on-X workflow for 2026, like I said. And I'm going to go through it step by step. So before I even talk about the workflow, like I said, I want to talk about something that is just as important, the great differentiator. This is just as important as the workflow, and it's going to make your workflow even easier, your whole surgical workflow. When patients come in for All-on-X surgery, this includes the consultation, by the way, before they even commit, they're almost always extremely anxious, right? And it makes sense, and I'm sure you've noticed this. First of all, it's not a fun procedure to get your teeth out and have tiny little screws screwed into your bone. I mean, that makes sense, right? That's totally a reasonable feeling to have as a human being. For most of these patients, this is one of the biggest dental procedures that they're ever going to go through in their lives. They've often been dealing with dental problems for years or their entire lives since childhood, probably dental trauma too, and they haven't been to the dentist in years either. So, horrible past experiences, and they're worried about pain. They're worried about the outcome. They're worried about whether they made the right decisions or how much money that they're going to spend to top it all off. They're just filled with worry one way or another, right? And here is where the great differentiator comes in. And what is this great differentiator I keep talking about? It's your team. Your team is actually part of the entire All-on-X process, the whole workflow. A very important part of that too, okay? And I don't just mean your surgery workflow or your surgical assistant who's helping you out. I mean your entire office environment, the front desk, the assistants, every single person in your office is participating in this workflow either directly or indirectly. For example, if your team is welcoming or they're warm, nice, calm, confident, all the good virtues, right? Organized, the patient immediately feels safer and more at ease on their surgery day or their consultation day. But even the small things like personalized care and attention matter too. For example, I did a double arch a few days ago and the patient was like absolutely terrified. Very, very sweet patient, but terrified from her previous dental experiences. So much so that she was about to back out after she paid. She texted us a week before and was thinking about backing out. Not only did my treatment coordinator call her, but she texted her daily, reassuring her that it's going to be way easier than she thinks it is, and that she deserves it, and she's going to love her final result, and so on and so on and so on. And on top of that, before the surgery, we all knew that she was terrified, right? We were all communicating, so we portrayed the exact opposite emotions. Everyone was happy to see her, everyone was excited for her, but also very relaxed at the same time. And that plays so much into the psychological state of the patient. So we continued, she got numb, she fell asleep, and the double arch was completed. And voila, without an ounce of anxiety present in the patient, the day of. I mean, she was a little bit nervous, but nothing like how she was. And not only did she cry at the end from joy after having all her teeth removed and like 10 implants placed in, and like half drooling blood and saliva, that we are the best, and it was the best dental experience that she's ever had. But on top of that, she was half sedated and she wanted to hug my treatment coordinator for reassuring her and making her feel cared for the entire week prior. These are the human touches and the personalized care and the experiences that truly make a difference, especially for All-on-X or dental surgeries. The whole office experience needs to be ingrained in your workflow. And that's step number one of the entire workflow. One of the biggest differentiators in our practice is that the entire team understands the All-on-X workflow, and they go above and beyond for every single patient, including our consults, and not just the paying patients, right? Everyone knows their role and everyone is an expert at it. And the patient can feel that confidence or that energy and that care that the moment that they walk into our office. And that matters so much more than dentists realize to the success and the ease of your complex cases. So now, before I get into the nitty-gritty workflow details, as you've been waiting for, I'm gonna take a moment to touch on sedation and what I personally do for sedation. And this could be a controversial topic sometimes, right? And it's quite strange, but anyways, another part of reducing anxiety is obviously offering some sort of sedation. For the vast majority of cases, and I mean like 99% of my All-on-X cases, including my double arches, I do oral sedation. I very rarely use general anesthesia, maybe like 1 or 2 cases a year. Oral sedation, at least in my hands, works extremely well. And if your office experience is like I talked about in the beginning and you work quick, obviously still at a high quality, and you're calm and your team is calm, it works every single time. My protocol is basically triazolam the hour before. They bring the other pill with them, and then they take the other pill once we complete the upper arch, if we're doing a double arch. This obviously varies patient to patient as well, but the goal is simple, right? We want the patient to feel calm and comfortable, and ideally, we want them to remember very little about the procedure itself, which is exactly what oral sedation does, right? Amnesia. So once my patients are numb, they're all snoring on oral sedation. I mean, they're out, and I don't need them to be cadavers like with general anesthesia. With oral sedation and 45 minutes to an hour, I can complete an arch. They're taking a nap. It's good. It's predictable. I don't need to schedule out for an anesthesiologist or have the patient pay an additional $3,000 to $4,000, unless we truly need it, of course. And guess what? Patients walk away saying something that we hear often. That was much easier than I expected. Okay, and that's all on oral sedation. And that's all that matters at the end of the day, right? Making the experience comfortable, easy, and efficient for the patient. So with that said, let's talk about the actual details of the workflow. You first need to understand that All-on-X is not just surgery, and the surgery and the teeth are only one part of it. It's a complete system, okay? And every system needs every single part of that system to be done well. And that system is broken down into 5 parts, and that's what I'm going to cover. I'm going to cover the case selection and the planning. I'm going to cover the pre-surgery setup, and then I'm going to cover the surgical setup and the surgical protocol, then the immediate temporaries, and then the final zirconia. And every single one of these steps matters, but like I said in the beginning, the real great differentiator is your team and the office experience. They matter much, much more. If that's not dialed in, you'll either not do any cases or you're going to have an awful experience with the cases that you do get to do. But with that said, let's start with step number 1, selection and planning. Aside from your team and the office experience, planning or lack of planning can make or break your case. One of the biggest mindset shifts when it comes to All-on-X is basically understanding this. All-on-X is not just implant dentistry or surgery. It's prosthetic dentistry, so teeth, aesthetics, and bite, supported on the foundation by implants. Implants are the foundation, right? They're the support, but everything else, like a house, the structure of the house, the layout, if we're making a house, the analogy is just like that, right? Everything else is very, very important. You're not just focusing on the foundation, and that distinction between the prosthetic dentistry and the implant dentistry matters so much because the final teeth are going to determine everything for you. They're going to determine where you place your implant, so implant position. They're going to determine the bone reduction that you're going to do, the vertical space, the thickness of the prosthetic, the speech, phonetics, or teeth placement, aesthetics, lip support, and then obviously they're going to determine the bite. And if those things are not planned correctly from the very beginning, everything is going to be so much harder, every single step. And if you don't plan vertical space and bone reduction properly, you can ruin the entire case. You can honestly ruin yourself and your patient by messing that up. It's that important. So our planning process, my planning process, starts with case selection first and foremost. There's a lot that can be said here, but I'm going to cover the most important basics for you in this video. First of all, if you feel like you really can't do a case or you can't make the patient happy, don't do it. It's really that simple. There will always be another case for you in the future, okay? And second, if deep down your gut, you feel like this patient is going to be a pain in the ass or is going to make your life miserable, don't do it. Not all money is good money. And third, if you're just starting, just choose the cases that are more straightforward, right? You're going to learn something from every single case, even the straightforward ones. You're going to get your reps in. However, please also challenge yourself a little bit. It's the only way that you're going to grow. Reach out for help, take courses, get a mentor, surround yourself with others that are doing what you want to do or the same thing. And if you want one-on-one help, by the way, whether it's clinically or with your business, click the link below. We help with that as well. Next is CBCT analysis. I want you to get to a point where you can analyze a CT and you can see if you can do a case within 30 seconds, maximum a minute. Until then, please get familiar with your CBCT planning. If you're doing guides, there's no shame in that, but please make sure you're not relying on your designers to plan everything for you. Eventually, you're going to need to transition to freehand for surgery, for all-on-X surgery. And the only way you'll be able to do that is by getting familiar with the CBCT planning for yourself, okay? Learn all of the views, what to look out for, what position you need for implants roughly, and so on. We have clients that get so much out of this, just the CBCT portion, when they come and shadow us in our office one-on-one, just that real-time planning in the office, okay? The next step is smile design. The most important part in this step is your photography and your records, meaning your scans, okay? How well you take your scans and how you're taking your scans. I made a video about the best and most affordable photography setup, by the way. I'll link that below, but please watch that if you haven't. Okay, now photos. Well-taken photos are going to be the key to your digital pre-planning, pre-design. You need to take these photos, which include a smiling front face photo, a maximum smiling photo. This one is key, by the way, and I'll explain this one next when we go over bone reduction and how critical of a photo it is. I'll also give you a few tips on taking it every single time. But then you also want some side smiling photos. They're retracted full face photos, retracted up close, and then retracted left and right. Make sure that you get these every single time with your records. Next, get good intraoral scans, including the whole palate and as much tissue as you can get, and obviously get a bite too. By the way, DM me if you have any questions or any challenging bite cases or dentures. I don't want to make this a video, like a 1 hour long video and just scanning and records and a bite. I'm just assuming you have a stable bite. So take your scans and photos and then submit them to your design lab, okay? They're gonna take those and they're gonna give you a pre-design of the proposed teeth on the photos, on the face, size, bite, how far they flare out, and so on, okay? One thing to pay attention to here, aside from making sure that obviously you like the teeth and the placement, the midline, all of that, the positioning of the teeth, is look at the teeth in relation to the gingiva or the existing teeth. That's going to help you determine your implant placement. It's also going to help you determine the angulation, including your MUAs, okay? So you're either not too facial or too palatal to create unnecessary thickness. And next, and quite honestly, the most important part of planning is bone reduction. Now, you may be wondering, how am I going to plan bone reduction? There are two concepts that you must follow, but the most important one is the smile lines. The other is prosthetic thickness, and I'll briefly touch on that, but please pay attention to the maximum smile lines, okay? And how low the lower lip droops. For the upper lip, take a photo of the patient giving you their maximum smile. Now, you really have to instruct these patients to give you that smile. One thing that you can do is tell them to bring their upper lip to the ceiling, okay? Using the corners of their cheeks and closing their eyes. Usually that works, and they understand what you're trying to tell them. Just make sure that you show them while you're explaining this. And if they really don't get it, use your fingers and lift the corners of their cheeks so they know what muscles to activate. And by then, everyone knows what to do. As they're doing that, smile, take a photo. That's going to be your reduction guide. measure from the free gingival margin to the lip, and then add another 2 to 3 millimeters for safety to really hide that transition line. Record that measurement and you're good. That's where you're going to use for your reduction later on in the surgery, and I'm going to show you a video of how that works in the mouth, how to translate that. For the lower arch, especially for older patients, especially males, make sure that you reduce below their lower lip. You also don't want to see that transition line either. Lastly, another reason that you want to reduce bone is enough prosthetic thickness. At least 12 to 13 millimeters from incisal edge to the base of the prosthetic, more if you can, but usually if you reduce enough bone for the smile line, you're good. And make sure to double check your thickness. Most of the time, you're also lengthening the teeth or opening the bite, so that also adds thickness, but make sure to check that. I hope by now you've realized the importance of case selection and planning, and you've realized implants are not really the starting point at all. The final teeth are the starting point, and your own confidence is so important. And everything else supports that outcome. Now a quick side note for a moment. If you're a dentist watching this, and if you're not a dentist watching this, it's quite impressive actually that you made it this far, but if you want to see this entire workflow in person, we do offer a 1-day surgical shadowing session at the practice. You can come in, you can see the planning process from A to Z, the surgery, the temporaries, the entire system from start to finish, all in 1 day, including our team. And it's also a good way to see if our one-on-one clinical and business help would even be a good fit for you. But with that said, let's keep moving on. Now, I want to talk about the surgery itself. Again, I don't want to make this a 2-hour video on just surgical techniques, because I definitely can, but in this section, I'm going to cover the most important points that you should know and the techniques that will not only make a difference in your surgeries and make your surgeries better and more predictable, but also more efficient. And one of the biggest principles for me during surgery, especially all on X, is visibility. You need to see like what the hell you're doing, right? Not only will you have better visibility of what you're doing, but properly done larger flap reflections is going to reduce your bleeding, and it's going to make your workflow so much more efficient. Again, it's going to help with visibility, with anesthetic longevity, and post-op pain. And then on top of that, with full visibility, because of your larger flap, you're going to get better bone reduction. You're going to get better implant positioning, and you're going to have better soft tissue management. And guess what? Your surgeries are going to be more predictable, and they're going to be better. Now, speaking of bone reduction, like I mentioned earlier, bone reduction is one of the most critical steps that you really can't mess up. So you know why bone reduction matters from earlier, so I'm just going to go over my technique briefly. Although I want to reiterate again, every single one of these sections can be like a 1 to 2 hour video or more. That's not the point of this video. What I'm aiming to do with this video is give you a very good overview of all the steps. So any questions that you may have, or you want to dive deeper one-on-one, just let me know. Okay, so you're going to translate your reduction measurement that you got from the photo onto the bone that you have reflected. Use a perioprobe, measure from your reference point to the reduction area, and mark that with a sterilized diving pencil. From there, mark a few points, connect the line, make sure it's straight, and second, confirm the thickness from the proposed incisal edge to the reduction line. Make sure it's at least 12 millimeters, especially in the posterior. That's where typically I find dentists under-reduce, and then they end up with very thin prosthetics in the posterior. For reduction, I prefer a 1-to-1 surgical handpiece with straight zirconia burrs. They seem to last much longer, they don't collect any bone, and you're going to make sure everything is smooth and flat. No hills, it just needs to be a sharp or a smooth area with no sharp areas, with no irregularities, just very smooth, like a table, okay? Next is implant distribution. For implant positioning, I follow the classic distribution, okay? Anterior implants, more vertical, for 90% of my cases, posterior implants tilted, maximizing that AP spread. If I'm placing 6, that's typically a palatal root implant on the upper, or pterygoids, or molar implants in the first molar position on the lower. In that case, make sure you place your posterior implants first. That's going to determine your spread, and it's going to determine your boundary. A quick tip for implant drilling and placement: if your bone is super soft, utilize VersaBurrs. And my typical drilling protocol, for example, for a 4.3 millimeter implant, unless we're in like solid D1 bone, is spear drill 90% of the length, 2.0 100% of the length, then every other drill after that 50%. I usually go to 4.0 at 25% for the 4.3 millimeter diameter, but it all depends on bone quality. What you're basically trying to do is maximize your chances at high initial torque with this technique. And if your torque is too high, you can always back out and re-drill, right? But you can't do much about bad torque, low torque, other than drilling deeper and using a longer implant, hoping to reach some cortical bone that's deeper. With that said, my go-to implant sizes for standard all-on-4 on the maxilla and the mandible are 4.3 by 13 for the posterior and 3.75 by 11.5 for the anterior. Now again, that changes based on the width and the height available, but I'd say 80% of my cases utilize those two sizes. Next are the multi-unit abutments, the MUAs. The MUA choice is incredibly important for your axis holes and in turn your prosthetic thickness. On top of that, you want to make sure they're as parallel as possible. My go-to MUAs for the upper arch are 30 degrees for angled ones and 17 degrees for the anteriors on the upper. Sometimes straights work as well, but you really need to keep an eye on the divergence of the upper. I've made the mistake of trying to really avoid prosthetic thickness by angling them out, flaring out my MUAs towards the occlusal or the buccal as much as possible. But in turn, I got insane divergence numbers. You can't do that either, right? Your prosthetic is not going to fit. It's a fine balance between positioning and parallelism. For the lower, it's usually straights on the anterior, 30 for the posterior, and if you're doing first molars, sometimes 17, sometimes straights. One other tip for optimal MUA placement is stop torquing in your implant about 0.5 to 1 millimeter supracrestal. Check your positioning of the MUA, then retorque to your ideal position. See how much more you need to spin it. Hopefully that made sense. Okay, so you've placed your MUAs. Next is capturing the position of those implants. In 2026 and beyond, if you're serious about All-on-X, you need a photogrammetry unit, or at minimum some kind of positioning unit or some kind of grammetry. I personally use the micromapper. We place the scan bodies, scan in a few seconds, and upload that file to the designer. Next, we go on to suturing. Don't worry, I'm going to talk about the intraoral scan as well and my technique there. But there are a few tips that I like to give you on suturing itself. Okay, for the upper jaw, please utilize the poncho technique as much as possible. I won't explain it here in great detail, but instead I'm going to link the quick 1-minute video that I made below, and that's going to guarantee thick KG on your upper anterior implants. Sometimes you can get them on the posterior ones. For the lower arch, please utilize intraosseous suturing techniques. Again, I've linked that video below as well for you to watch. And the reason for these techniques is simple. You'll stabilize the tissue, position the keratinized gingiva where you want it, and the healing is going to be so much better and so much more predictable. Lastly, please develop a sequence. For example, for the upper arch, I place one midline suture, I suture the 2 vertical cuts, and then a couple sutures in between the implants. That's it, every single time like a recipe. It's going to make your suturing also more efficient. Now you're done suturing, you're ready to scan. Place whatever scan bodies you prefer and start scanning. Make sure that you go in one direction, you get the arch form, outline the arch, and then you go buccolingual, 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 capture the entire palette for the upper, and capture your reference markers. This is for the upper. For the lower, there are so many techniques out there, so many ways to skin a cat, but here's my favorite. Before you suture, keep your scan bodies on, capture an alginate impression of the bone and the implants and your markers, and scan that impression. Why alginate? Because at least for now, at least in my experience, maybe it's only me, whether it's the Trios or the Prime scan, I can't get an open flap impression on the lower arch. It only works when we scan a solid impression. Now, why am I taking an open flap impression for the first place? For a few reasons. You can send these files to your designer as they're designing, and then you're suturing at the same time. Now you've saved time, so instead of suturing, scanning, and then waiting, and then the scan is still a pain in the ass when you're scanning the tissue, you save time. Second, on top of time saving, you're telling your designer to design the intaglio flat 1 millimeter away from the bone level, depending on tissue thickness, but nice and flat. This is going to give you optimal tissue healing on the lower. Nice broad tissue healing. Now, after the surgery comes the temporaries, the immediate temporaries, that you are going to get a design of and you're going to print. Please keep this in mind. Your immediate temporary is going to determine how successful your final prosthesis is going to be. Why? Because the temporary is going to determine your tissue healing. How your tissue is going to heal, the occlusion, the forces, the phonetics, and of course the aesthetics. That's why paying attention to the implant positioning, the multi-unit abutment placement, and the intaglio, the flat intaglio, is so important. My guideline based on my workflow is 1 millimeter of tissue pressure on the upper, completely flat. And then for the lower, like I said, 1 millimeter away from the bone, also completely flat. If you follow this, you are going to get tissue results like these in these videos almost every single time, especially if you follow the suturing techniques that I talked about in those videos that I've linked below. Now it's about 3 months after, roughly 12 weeks or so, and healing is complete. Now we move on to the final zirconia prosthesis. Here's what I do. The assistant scans the upper and the lower teeth and the bite. They remove the temporaries, they check the cleaning and the tissue, and then they call me in to retorque the abutments. Don't forget to retorque your multi-unit abutments. Then the assistant places the micromapper scan bodies, takes the photogrammetry scan and the tissue scans, and then places the temporaries back in. I confirm the scans look good, and then we sit down and we go over the temporaries. What the patient likes, what I like, what we dislike together, or if we even dislike anything. If the changes involve anything related to the bite, I make a second set always. If it's minor aesthetic changes, I take a photo and we go straight to finals. But remember, this is key. Make sure you are 100% happy with the occlusion before you move on to finals, including your vertical dimension. My finals, by the way, are a mix of titanium bar and zirconia, or sometimes monolithic zirconia. Briefly, tie bar for pterygoid cases and implants that are too close to each other, any cantilevers or clenchers or grinders. Monolithic zirconia for well spaced out implants, especially for implants. Now, with the workflow complete, I want to end off with marketing and how you get patients so you can actually do this work consistently. You can learn the workflow, you can learn all these details, you can take the courses, shadow in our office and whatnot. But if you can't get the patients, you're not going to utilize your knowledge or your skills. Marketing is something that I do every single day. And by that, I mean, I've been running a marketing company specifically for dentists looking to do more implants for over 3 years now. The battle in dentistry, especially in implant dentistry, is actually getting the patients in the first place to do this work. And I don't want to make this a marketing video, by the way, or to sell you my services, not at all. That's why I'm leaving it for the end, but that doesn't mean that it's not important. It's actually the most important part aside from your team, so you can actually do the work. But if I had to summarize marketing and marketing success for implants, you need to build a solid team and solid systems. Without these two, without the team and without the systems, without a sales system and a solid team, your marketing is going to suffer. You're going to waste thousands of dollars for poor results. Take a look at my TikTok, by the way, for some marketing and systems-based short content. But if you want to dive deeper on systems and your team, just click the link below and we'll see how we can help you with that. Because that's truly what we work on. Now, listen, All-on-X is one of the most rewarding procedures in dentistry. You utilize many skills, you transform patients' lives, you give back their confidence, you give back their lives in so many ways. You also make a decent amount of money doing it, but it only works when the entire system is dialed in. From the planning, to the surgery, to the temporaries, to the final zirconia, and patient acquisition. And most importantly, reliable acquisition and a solid team. You can't just dabble in this. You need to go all in, okay? And if you enjoyed this video, make sure you're subscribed because I'm gonna keep making videos like this. I'm gonna go more in detail. I'm gonna try to put out content that I would wanna see as a dentist a few years ago. Until then, I'll see you in the next one.